Good afternoon, ladies and gentlemen. Welcome to this Gloucestershire Live briefing on behalf of Gloucestershire Hospitals. This is the third in a series of sessions. For those of you who have been following these, remember the first one was on COVID-19, second one last week on gastroenteritis. Today, we're going to be talking about acute medicine, but this is all about the future of our hospitals here in Gloucestershire. My name is Ian Mean. I used to run the newspapers here and in Bristol for some years. I'm an independent. I like to ask difficult questions. We've got the Chief Executive of Gloucestershire Hospitals, Deborah Lee, here, who's going to be answering, hopefully, some of those. This is how it's going to work. We're going to talk about the acute services. We're then going to talk about COVID-19. And for those of you who look at Points West, you must have been really moved last night to see Nib's footage of the COVID patients. And then at the end, there's going to be some questions from you. The key thing, this is your chance to question the trust. You'll see on the bottom of the screen a chance to fill in the online survey. Please send in any questions, both to the Gloucestershire Hospitals Facebook page and to Gloucestershire Live. So I want to start by introducing our panel, so to speak. First of all, Deborah Lee is Chief Executive. Very briefly, Deborah, how many staff do you have in the trust?
Just shy of 9,000, Ian. I think we're the largest employer in Gloucestershire.
Absolutely, and people probably don't realise this, that in every county these days, hospitals are the largest employer, in my view, quite rightly, and we've seen them really rise to the occasion in COVID. Second person I want to introduce to you is Rob Stacey. Rob's A&E consultant and a speciality director. Rob, what do you do?
Good afternoon. So I am an emergency medicine consultant, which means I work clinical shifts in both of our two hospitals in the emergency departments. And then as clinical lead, I am the lead of a team of 18 consultants on the junior doctors and nursing team within those two departments.
And they're spread throughout the two hospitals in Cheltenham and Gloucester.
Yeah, so essentially all our staff groups now rotate. Our nursing team are getting into a stage now where they're rotating more frequently, but the medical team have rotated between those two hospitals for many years now.
Okay. Nabil Jarad. Nabil is acute and respiratory medicine consultant. Welcome, Nabil. Can you give some people the idea of what you do?
Good afternoon. The job of acute medicine is to work side by side with ED. So if someone come to ED, for example, who had a hand injury,
the emergency department.
It is the emergency department. If you have a surgical issue such as appendicitis, you go to the surgeon. If you have an injury, the ED department does that. The majority of other presentations are called medical presentations. And these are wide range of presentations, mainly chest pain, breathlessness, severe headaches, frailty, and people who are taking inadvertently high dose of medications. And I'm part of 8 acute physicians and large number of nurses and physiotherapists. We are based side by side in the emergency department, but we also man the acute medical units. And we also man a large unit called the ambulatory care unit, who sees the patient as a day cases, manage them and return them home. We have the largest proportion of our work is in Gloucestershire, and there are a small proportion now of our work in Cheltenham, but the two units work together in a symbolic way, but also we work extremely closely with the emergency department.
Thank you, Nabil. Now, Helen Newcomb. Helen is an advanced clinical practitioner in A&E. I'm a big fan of 24 Hours in A&E on TV, Helen, and I see a lot of practitioners really at the heart of the emergency department, almost doing, well, doctors' jobs. Can you tell me about your
My background
role?
is I am a nurse. Absolutely. So I am a trained nurse. I am an autonomous practitioner within the ED team. And I see both paediatrics and adults with a range of minor illnesses and injuries.
Fine. Thank you very much indeed. What I want to do now is go on to get into the ribs of literally what is acute medicine. I had a different view of this. I just thought it was serious things. But Deborah, can you tell us why acute medicine and the organisation of it is so vital to the trust?
Absolutely. As you know, we're talking about this programme, we call it Fit for the Future, because it's really easy, isn't it, you're in hospitals to focus on the here and now. We're very present, it's very busy, but in fact, thinking about the future is a really important part of my role, and increasingly clinical colleagues wanting to join me in that thinking. So what we've got here is an expression of a really ambitious and exciting vision for our hospitals in Gloucestershire. When I landed here, 4 years ago now, I think our two hospitals were seen maybe as a bit of a problem, might even have been sensed to have been in competition with each other. What we've done is to turn that around and say, what an amazing opportunity. Many of my colleagues up and down the country would die to have two hospitals that they could develop into these centres of excellence. We did it almost by accident, didn't we, with cancer services many years ago, when we decided to centralise and specialise cancer onto the Cheltenham site. And as a result of that, and that really for me is the blueprint for these centres of excellence, what we've got now is a not just a nationally leading but a world-renowned centre that attracts the best and retains the best and is delivering just world-class healthcare. So that's the vision. That's what I want for every service, not just cancer services. And really important final point for me, Ian, is that I don't think I understand why we spend a lot of time talking about the 8 miles between the two. I really do understand the value of local care. But what we don't talk a lot about are the hundreds of patients who go to Birmingham, Oxford, Bristol for care that we, under this vision, could deliver in Gloucestershire. You have a heart attack in Gloucestershire outside of daytime hours, you'll go to Bristol. You won't be cared for locally. And we can do it. We can do that here. But we need this kind of strategy to take us there.
Yeah. But I mean, we talked about this before. Isn't this really a no-brainer? Isn't it logical to have your key talents developed in one centre where all the expertise is? That's what companies do.
Yeah, and I think on paper it is a no-brainer, but what's great about Gloucestershire is people are passionate about their health services and about local health services and getting the balance right between what we continue to offer locally. So, for example, if you are unwell, you might be coming to hospital. One of Nabil's respiratory patients might be coming very regularly, and so what this model doesn't do, it doesn't unpick outpatients, which we'll continue to have on both of our sites, and imaging on both of our sites. So it says let's keep local what we can do locally without any detriment to quality or people's outcomes. But when we know we could give somebody better care, better outcome, maybe survive when they wouldn't otherwise have done, maybe keep a limb when they might otherwise have lost it, have keyhole surgery in major surgery, then it is an absolute no-brainer. Absolutely.
And of course, we've seen oncology become almost world-renowned, haven't we, in Cheltenham?
Yeah, and it's not almost, it is world-renowned. And we are attracting professionals who, before they came to chat to us, went to the Marsden or the Christie, and we're employing them, because of not only what we do here, but our vision. You'll be familiar with our vision around the Gloucestershire Cancer Institute. It's so exciting, and this is more of that, but for other specialties that haven't had the profile that cancer's had. Yeah.
Now, Rob, you're at the sharp end of all this. I understand that you work separately from acute medicine, but you have the patient coming into you first, don't you, generally?
So if if you have sort of an emergency care need, then yes, you might well see me first. But it would be true to say that my acute medicine colleagues will also be sort of at that front door of the hospital. So if you've had cause to see your GP and be referred in with breathlessness, as the example we've used before, you might see my acute medical colleagues first. So if you come by ambulance, yes, I and the team within which I work are the people you're likely to see first. And as I said in the introduction, we work across both sides of the county in our two hospitals, and that is to continue to be the case. Deborah was responding to your question about those concerns about local healthcare, and the Fit for the Future programme describes a department in Cheltenham that will continue to see those people with urgent healthcare needs, and a department within which I will still work. So I will continue to see people on both sides of the county at that first point of entry that you described.
Yeah. Now, Nabil, centres of excellence, what's your view about that in terms of the acute medicine side?
So 5 years ago, if someone presented with chest pain and we suspected that the patient may have clots in the lungs, we had to bring the patient into the hospital, stay for 3 days, wait for the scan to happen, and then keep the patient for 2 more days and to make sure that they are treated. Now we have tools in which then they give us immediate diagnosis. We have radiology and we have ECG, and more so, in fact, we have the understanding of the condition to make sure that the condition that we needed to treat and diagnose for 5 days, we can do literally within a few hours, because we have immediate radiology and we have immediate understanding, and we can treat, return the patient home and give them a call in a couple of days and say, are you all right? And then we will discharge them. Yeah. And Center of Excellence is not only using modern tools of making a diagnosis and treatment, but they have modern understanding of the acute specialties, which in the past used to keep the hospital, to keep people in hospital for a long period of time. But now we just do the diagnosis, start the treatment, and return them back. Another important example is the chest infection, especially with the area of COVID now. And chest infections, we used to actually keep in hospital with the pneumonia for 2 to 3 days, give them intravenous antibiotics, send them home. Now we give them a couple of doses of antibiotics within an outpatient environment and send them home on oral antibiotic with similar outcome. Yeah. So Center of Excellence is new tools, new understanding, and highly competent and high quality staff, not only from the medical staff, but also from all other disciplines.
In brief, Nabil, what needs to happen now then? What is your preferred option for acute medicine?
So Deborah mentioned the short distance. Really, in fact, the preferred option is to see that the staff, the big bulk of staff and the big bulk of facilities focused in one place, perhaps a Gloucester General Hospital being that place. And this is really, in fact, for the benefit of the patient, with the expense of people traveling the distance, if you like, between the two places. And this is really the preferred model that acute medicine and indeed respiratory medicine prefers.
Yeah.
And Ian, probably just worth if I can come in, because I think, you know, if I imagine we've got this pyramid and people worry, don't they, that everyone at the bottom of the pyramid is going to have to travel for care. And what Nabil's describing is the people that are right at the top of the pyramid. This is a small number of our most unwell patients. And I guess as Nabil's described, this is access to quite a scarce resource. You know, people like Nabil sadly don't grow on trees. These are real specialist people with specialist knowledge. They require access to equipment and technology that we simply couldn't put in the county twice. And we did look at that because we understood what the people in the east would feel. And we did look at that. And we looked at whether we could put it Cheltenham or Gloucester, and you know, really thorough assessment of all the options before we landed on what, you know, we would describe as our preferred option. But 80% of those that that use Cheltenham, let's put it pre-COVID, you know, the usual people that would have used Cheltenham will still be able to use Cheltenham. You know, this is a major service, and people like Helen, you know, will be absolutely driving it to be even more accessible and deliver, you know, more care than it does now. Particularly for those who can keep out of hospital.
Sorry to interrupt you. Helen, can you talk about that point? These hospitals are only 8 miles away. You're at the centre of all this. You're in the front line. What's your view on all this? On acute medicine,
I think it's really important to mention it.
Yeah, okay.
Yeah, absolutely. I feel that what we're proposing is the patient will give them gold standard treatment. It's about getting the patient the right care in the right place to see the specialist at the earliest possible convenience for them. And by centralising that care and consolidating that care, will benefit the patient.
And is this a view that is held by your team? Is that a general feeling?
Yes,
of the
obviously our patients.
Yeah.
Absolutely. We want what's best for our patients. We strongly believe that this is the way to get that best standard of care.
Yeah, that's great. Thank you very, very much, Helen. I want to talk to you after about COVID, but I want to move on to that now. And before we go into the figures, and before we perhaps talk a little about this amazing film that the Point twisted last night, Deborah, you know, I follow you on Twitter. You're very active there, and you've been talking a little bit about the whole mental health issue, haven't you? And I know your son has been involved in helping patients.
Gosh, you've done your homework. Yeah, I did a rare personal tweet this weekend. I tend to tweet professionally, but I did have a proud mum moment. Gabriel, student. He's a bit of a local celebrity around the hospital because he worked here for 5 months during COVID as a dustbin man. He worked in the porters team. I think he might have been called a waste operative, but emptying bins. But yeah, Gabriel, you know, like many students, had a decent summer, not doing much online study and enjoying the weather. But they're all back now, and I think it's only now that the real impacts of being a student in isolation. Gabriel has 12 hours behind the screen. He has no contact with people, and he sees friends around him, you know, struggling to cope with that. And the context there is what's been really, I think, quite a harsh narrative on many young people about being the super spreaders out partying and, you know, causing this second surge. And, you know, I've seen some of those behaviours, but I've also seen a lot of incredibly responsible students. But yeah, very sadly, Gabriel's best friend shared a house with Lily Arkwright, who was a student in Cardiff, and Lily took her life 3 weeks ago. And her parents fundamentally and wholly believe that was because of the impact of isolation and lockdown on her as a student. They described the lights of having gone out. So Gabe has been really impacted by that. And to my absolute kind of credit, and this is again the proud mum moment, he turned that into a positive and ran a mile on the hour, every hour for 24 hours, wanting to connect with that sense of mental, you know, anguish. And in doing so, he raised £1,500 for mine to work with students on student mental health. So yeah, I was pretty impressed. Did it without any kind of, you know, I wasn't doing my usual tiger mum behind the scenes. He did that of his own accord. So yeah, delighted.
Great. And just one question on mental health. I mean, you've got 9,000 people. A lot of those people will be affected. How are you helping them?
Yeah, and it's really important, isn't it? So we're doing lots of things, and this is both about trying to prevent somebody from having, you know, a mental health illness down the line by being really proactive about well-being. So promoting the importance of, you know, you don't look after yourself, you can't look after your patients. Lots of access to tools online, face-to-face. just trying to remind people of the importance, doing the practicals of just making sure we understand how many hours people are working, some formal support, psychological link workers, we call them, that title, people just working in and amongst their colleagues with an extra sort of eye and an antennae out for those that might be struggling. But I think probably what I would hope moreover is we're kind of trying to get this message out that it's okay not to be okay. Because I think too many of us, either with the kind of British stiff upper lip or not wanting to be the one that falls first and leaves colleagues in the lurch, we just keep going. But saying I'm not okay and getting help is the right thing to do. And that's something we're encouraging all of our colleagues to do and to feel comfortable to do, and for that to be seen as a good thing, and nothing other than that.
That's great. Now, COVID, we've just heard from Downing Street, the latest figures. They are the highest fatality figure since May, 598, the latest figure. But none of us could be more humbled, I think, than looking at that film on Points West last night. And could you tell us today what the latest figures are, but what is the trend in this second surge?
And it's interesting, isn't it? Because I sat here only a week ago talking about some very different numbers. So just to give you a context, in the first surge, the first peak, we had 148 patients in our inpatient beds at the peak point. And today we've got 132. So we're fast approaching that, that peak. I hope we may not exceed it, or if we do, not by much. So back to a question about trend. The rate of new cases coming into our hospitals each day is slowing. We were about 22, 23 for 4 consecutive days. With the exception of one day that was a bit of a peak day, we've had 10, 11, and yesterday just 6. So, slight sign that it's slowing there. Similar to the picture I painted last week, about 60% of those patients are over 70, so still largely affecting older people, although as we saw from the great film last night, it also affecting the people. Really interesting statistic, although it's early days. We've had just shy of a half the number of cases overall so far in the second surge as we had in the first, and 8% of those have succumbed and have died. It's 31% in the first phase. That's a huge improvement in mortality and in positive outcomes, and we're attributing that to a whole raft of things. You've heard Dave Windsor talk very eloquently about, detecting more people, getting treatment sooner, the role of steroids, dexamethasone in those treatments. So it's no one single bullet, but it's positive. And also, although people are older, the signs are that they are fitter in terms of their underlying health. So far fewer coming into us from care homes. Sadly, that is because many of those did succumb in that first wave, but just gives you a good indicator of how poorly people are. On average, at the moment, someone with COVID staying with us 4.3 days. In the first phase, it was 11 days. So that's a good sign that people are, less, not deteriorating. Critical care, we had at the peak 33 patients on critical care. As with this similar peak, we've got 5 today. So again, people not as sick, recovering more quickly, better treatments. It's a great story, but I want us to bring back to the fact that those that didn't lose their life were really poorly still. So, if anyone thinks that, this isn't as bad, I'll run out and have a party or take my mask off, it is just as bad.
So before we just get to some questions, your big message, very briefly, Deborah, is what still?
So we're in the week when we said that the impacts of lockdown might start to be felt out in the community. We're just on the cusp of maybe seeing that. So my message is that we need to keep going with this. Our goal for Gloucestershire has to be not only to save lives, which I wholly believe the lockdown's doing, but to be one of the regions that comes out into tier 1 so that we can get back to as much normality as possible, pending the vaccine, which, I remain really optimistic about. I get all the caveats about safety. They're all incredibly important. But we will have a vaccine sometimes next year. And so, hang on, and really, really work with us on complying with the requirements of lockdown. It's the basics, Ian, isn't it? Don't hear a lot of people talking about the 20-second hand wash, but please, wash your hands, wear your mask, socially distance, and don't go out unless you absolutely have to.
Yeah. Rob, can I ask you very briefly, quick message on COVID?
Thank you. So I would just echo the sort of sticking by the advice. It is tough in our hospitals at the moment. So each time you put on a mask and wash your hands appropriately, you are helping us out. And the other things, it's related to COVID, but it's the wider picture. That the health services that people might think are closed and not available, they are open and they are available. So Cheltenham is open. And I am still doing clinical shifts there. So if you have a health need that doesn't require an ambulance, then that's an appropriate place to go to for help. If you don't have a sort of an emergency care need, then our GP surgeries are as busy as ever, but they are hoping to see their own patients for appropriate conditions. Okay. And our 111 service is a service that will help you navigate some of those health services and help you address a care concern that you have. So please don't think that our services are closed. They are open, and we still want to see people when they have a need.
Yeah.
That's a big message. Nabil, very quickly from you, your message.
COVID is a virus that can only live and multiply in a human, and therefore preventing it from going from one person to another is the essential way to indeed smother the virus, if you like. And I can only reiterate what Deborah and Rob has said. It's just keeping the virus from going from one place to another is the quintessential way to controlling the virus. So washing hands, wearing masks and eye shields, and keeping the distance are really, in fact, the three pillars of controlling COVID.
Okay, thank you. Helen, your message?
I echo all of my colleagues' comments as well. Wash your hands, wear the appropriate PPE, and just keep safe. And especially, don't go out unless you really have to. Absolutely.
Yeah, just winding this up, I want to ask Deborah a question. Come in from David Willingham, and David says, "Why are you consulting on the future of Gloucestershire's hospitals during a global pandemic?" Good question.
It's a great question. I could refer you to the last two videos of the HOSC meetings where we've had a lively debate. And for me, it is relatively straightforward. We could paralyse our lives, couldn't we, with this? But I think, life has to go on, and we're all trying really hard to that. But to the point on this is that I wholeheartedly believe that these changes are going to bring benefits, and I don't want to slow the delivery of those benefits down by pausing. We've got momentum, and people are anxious about where this is going to settle. And so the sooner, particularly my colleagues that are working in these services, the sooner we can answer the question, the better for me. And we are going to just reflect on whether the lockdown itself means we need to go on a little longer because some of our face-to-face activities were paused and impacted. But actually, if we look at how people are engaging with us now, of all ages, actually it is this medium, it's this virtual stuff. So most of our approach to consultation has been through online, and we've had more engagement than we've ever had. When I used to go stand on a stage in a parish hall and hope somebody came to throw a tomato at me or cheer. So I for me, I just go back to, why would you want to delay bringing these benefits to the people of Gloucestershire?
That's right, and I think it's an appropriate message to all the viewers, listeners to these briefings, that the first one, 42,000 engagements, the second one, 49,000 engagements. These are big figures. I'm a media man, and I know these are very, very big, and it says something about Gloucestershire Hospital, how they're respected. And this is so important. So please fill in the survey. You can see it on the bottom, the ticker tape on the screen. Next week, we've got trauma and orthopedics. And please look at Points Western Eye. Another great piece of film about brilliant staff at Gloucestershire hospitals. Great human story. Thank you very much.
Thank you.
Thank you.